We'll move on to the plenary 3, that's arthroplasty. I have the pleasure in introducing Dr. Ananda Perera, MBBS, MS, FRCS, and FCSSL, Senior Consultant Orthopaedic Surgeon at the Sri Jayawardanepura General Hospital. He's a past president of the Sri Lanka Orthopaedic Association and past president of Orthopaedic Association of SAARC countries. He's the chairman of the Board of Study in Surgery of the Postgraduate Institute of Medicine in Sri Lanka and the chief examiner of the board of at the PGIM. He's a member of the AO Trauma, member of the AO Spine, and he is the foremost arthroplasty surgeon in the country, and he has performed more than 8,000 joint replacement and 3,000 ACL reconstructions to his credit. Over to you, Anand.
Thank you, Pinto. Thank you so much for the kind words. And let me start the talk immediately because there's running short of time. So my task is to give some tips and tricks for the primary complex knees. And these are my disclosures. And my talk, I will be covering about the complex varus knees, valgus knees, flexion contractures, and the extra-articular deformities, previous hardware and the post-traumatic OA, and the complex skin incisions, and the post-infected knees, and how to deal with. So basically, first of all, I don't go into details of the history and examination. You have to do that. That's very important. And but few things about the few important principles about the taking the pre-op assessment of the patient, the proper X-rays. So you need to get these X-rays definitely. So the proper AP, lateral, and the tunnel view, and the skyline view. Those are very, very important when you are doing arthroplasty surgery, and alignment X-ray. Now, that is something that we recently do each and every patient now, because there are so many times that you will find that your alignment is changed because of the extra-articular problems. So therefore, always try to get your long leg films when you are dealing with a knee for arthroplasty surgery. And there are a few points that I like to mention before I go into varus knees. Number one is that your main, the structure that tibia rotates is around the axis of the femur. That is one principal thing that you have to understand. The trans-epicondyle axis of the femur make the entire tibia move around that part of the femur. Now that is something that you need to know, because your implant of the femur make the most important point of your longevity of your arthroplasty. So therefore, make sure that you put your prosthesis on the femur in a proper place, and keeping in mind that your femoral component give the decision of your longevity of your arthroplasty. Number two is your disc, I call it a joint box or a bone joint box, and between the lateral and the medial collateral ligament attachments, that is the femur and the tibia, so the trans-epicondyle axis and the upper part of the tibia, that box, you need to remember that you have to be within that box of your cuts. You can't go beyond that, and if you go beyond that, you are in trouble. So therefore, these two principles I like to inform you, and particularly junior, the trainees, and these two principles you need to know when you are doing arthroplasty surgery, because if you violate these two, then definitely your joint replacement will fail. Coming to varus knees, the straightforward anteromedial osteoarthritis with the intact ACL and the correctable varus with the valgus stress, you can go ahead and do a uni knee replacement. So therefore, remember that if you get a varus knee, and don't think that even that is worse varus, but if you can correct it and with the valgus stress view, and your ACL is intact. Now, if I go back to your previous X-ray, if you look at this line, and that shows that the ACL is intact because the posterior wall, the tibia is good. So therefore, this is an anteromedial osteoarthritis and the ACL intact and correctable, whereas you go for uni knee. And you can make any incision you like. And I prefer paramedial incision for the arthrotomy, medial parapatellar incision. So that is my preferred incision, but you can go subvastus or midvastus. Now, these lines again important, as I mentioned, the transpedicular, the epicondyle line and the posterior condyle line. Now, the posterior condyle line, sometimes it's very important that not to go for that, particularly in the valgus knee. When I come to the valgus knee, I will explain to you that. And 3 degrees of this rotation has to be considered when you are keeping the implant for the femoral component, and that will give you a proper alignment of your femoral component. So therefore, these lines has to be known. Now, there are various classifications, but the varus classification is very well known, is the Pavisic classification, and that give you intra-articular, metaphyseal, and diaphyseal groups. The intra-articular, it could be anteromedial osteoarthritis, posteromedial osteoarthritis, or the complete both osteoarthritis with lateral instability or stability. And then you have to know what type of metaphyseal defect you have, and so on. So that is the classification that you need to know when you are dealing with the complex varus knees. And there are sequence of releases of soft tissues to balance your soft tissues in the knee, particularly when you are dealing with the varus knee. Now, this is Mulaji's the presentation of his method of releases. This is PS knees, where you remove the PCL, but this is what I do for because January 1996, I started my first knee replacement. And so that is 25 years now. So this sequence has done me in my hands very well. So what I do first is do a subperiosteal release on the medial structures of the MCL on the tibia. And then I will remove all osteophytes, remove all the osteophytes of the tibia, femur, and patella, and remove both menisci and do minimal tibial cut. And then you come to the femoral cuts. Now, once you do the minimal tibial cut and the femoral cut within that joint box, most of the time you can get gap balancing. Now, if you don't get gap balancing at that time, where you get laterally opening, that means your medial structures are tight. So the medial structures are tight. That's why the lateral side is opening. So then you do medial soft tissue release further. There you go from anterior to posterior. You release the posterior oblique ligament on the tibia and come back to the posterior midline of the tibia, the soft tissue release. So that you do quite a lot of medial release up to the midline of the posterior tibia. And you may go down to the pes anserinus tendon and release that part also with the soft tissues. And after doing that, most of the time, your knee balance will take place. And if you still don't get balancing, then you have to check whether it's a flexion gap or the extension gap is having the problem. If both are affected, then you do a tibial cut. If flexion gap is affected, you do a femoral cut. Extrafemoral cut. So that is the basically principles of varus knee balancing. Now, this is a basic knee, and that is a mild varus. So you do a correction with the proper soft tissue release and get the correction. If necessary, you might do the medial superficial medial collateral ligament releases as well, like this. But I usually don't do that. But most of the time, I can get balancing with the previous the steps that I already mentioned. Complex varus, now like this. Now, if you have that, you see quite a lot of bone loss on the medial side. And if you try to do the main cut up to that point, you lose quite a lot of lateral bone from the tibia. So therefore, you do a minimal cut, as I mentioned. You remove all the osteophytes. You have a lot of osteophytes. You remove all the osteophytes, then you will find that there's a huge defect on the medial side. So if you try to go down to that defect, you will lose quite a lot of bone. Therefore, what you do, use a minimal cut, and then you drill the defect. Then you cut the femoral cuts and get femoral cuts as a bone graft onto the tibia and use that as a bone graft and put your implant on that. Always use a stem extension, and then you put screws and then hold that bone graft, and then you put a stem extension and then knee replacement. If the patient has less than 5 millimeter gap, then you can do a bone cement augmentation, but always use a stem. If the ligaments are not balancing, then you can go for the condylar constrained knee. Or you can take, if you have a large defects, you can do a hinge knee with the metal bone blocks, and you can have a bone block. The defects can be counteract with using the bone blocks or the metal augments, right? Then come to the valgus knee. If it is a severe valgus knee where you get the laxity on the medial structures and the opening up on the medial joint line, and that again, you need to get the long leg films and make sure that whether it's a both legs or one leg, and what type of alignment that you are dealing with and how to correct that. And those things has to be kept in mind. So there is a classification by Ranawat and Karakor classification. There are two classifications. So both give a type 1, 2, and 3. And this classification will give you what type of soft tissue balance that you need to do. By going through that, then you know how much valgus you are dealing with, and then what to do. Now, recently, last year, there was a very good paper from San Diego, from the Argentina, and that gave a very good classification, which addresses all the important points of valgus knee. The joint wear, the knee deformity, ligament insufficiency, and the joint instability or stability. So that classification gave 5 types of classification: the narrowing less than 50% of lateral compartment, narrowing more than 50% of the lateral compartment, and the valgus knee of less than 20 degrees, and the valgus knee more than 20 degrees with the normal MCL, and valgus knee more than 20 degrees with MCL is lax. And then the severe deformity where there's a complete loss of medial structures, and then that knee has a recurvatum as well. And the last one, the type 5, you need to have a hinge knee. That is very important. And again, when I stress the hinge knee, always remember that if you are young, if you're dealing with a young in the sense as a WHO young, 65 age, so therefore still we are in the young age. So therefore we have to remember that the patients should be given a condylar constrained knee, because if you look at the literature, the long-term survival of the hinge knee is compared to the condylar constrained knee is much less. So therefore it's important that you try to give a condylar constrained knee rather than the hinge knee. But if you have a severe deformity with the severe ligament laxity, then you have to go for the hinge knee. So this paper is very useful classification. And then come to the, it's not moving. Yes, it's not moving. Lights are not moving. Right, okay, thank you. Right, so then again, in the valgus knee, what are the structures to release? Now, again, you have to go to the literature. You have a white side, the balancing literature about the how to balance your soft tissues, depending on the which side is, which flexion gap tight or the extension gap is tight. and then which tissues to release first. Now, there are so many literature came even after that. This is 2002. Even after that, there are so many literature came which one to release first, whether you go for a popliteus tendon first or whether the IT band first and so on. But this is what I do. This is in my hands. It works. Number one, do not release any soft tissues in the medial side of the tibia. That is the first thing to do. Not to release any structures on the medial side of the tibia. Remove all the osteophytes and do minimal tibial cut. Most of the time, people tend to do too much tibial cut on the tibia for the valgus knee, but don't do that because your joint line change. So therefore, try to do minimal bone cut first and remove all the osteophytes. And then you do gap balancing. If that is tight, then you can use lateral release on the femur, posterolateral release on the femur with your cob elevator and release all the attachment of soft tissues from the medial side and the posterior side of the femur. Once you do that, if the gap balancing comes, most of the times it comes, so that you can do total knee replacement by just these 3 steps. If necessary, next step I do is the popliteal tendon release. I release the popliteus tendon, and that gives most of the time, 90% of the time, the balancing of the soft tissues with the valgus knee. IT band release is the next step, and the last, the lateral collateral ligament release. And additional bone cuts are done if there is a femoral, the femoral or tibial the cuts are done only if the flexion or extension gaps are tight after doing all the soft tissue releases. Very important, remember these steps so that you will not forget that if you go according to the order, then you will definitely get a good reduction and the full correction of the valgus angle. Coming back to the valgus knees, this is a straightforward valgus knees. You can do soft tissue release and then get a good balancing, and that will give you a good alignment as well. But if you have a massive the laxity on the medial side, try to use a stem extension and a fixed bearing knee. And the advantage of putting a fixed bearing knee in with the implant with the stem extension is that if you need to get balance, you can, without going into a totally condylar constrained knee, you can just put the condylar constrained condylar the insert only. So that is the advantage. So that, but now I'm actually collecting data on that. We have done quite a large number of cases of just a fixed bearing knee with the condylar constrained implant, the insert, and that gives a very good balancing if the patient has laxity on the medial structure or the lateral structures in the varus knee. Now, the stem, very important another step is that not to cement your stem, because the stem is a load sharing. You never do cementing of the stem. If you do cement, then you get a stress riser in the lower down. So therefore, prevent putting cement down the stem. Severe valgus complex, so you have to do the soft tissue release, and if you can't balance, you have to go for a condylar constrained knee or a hinge knee, depending on the deformity. Again, coming back to this, the pearls and pitfalls of the complex valgus knee. Remember that never ever go for the posterior condylar, the line of the femur in a valgus knee, because a lot of time your condyle is wasted and therefore you may get a wrong impression on the cut. So therefore always remember that the epicondyle line is the best line, right? And the minimal tibial cuts, and also, as I mentioned, there are certain pitfalls in the valgus knee correction. Number one is the maltracking of the patella. If you have a maltracking of the patella, you can do lateral release of the patella. And sometimes I have done a severe valgus, I have done a lateral arthrotomy instead of medial arthrotomy, because knowing that the patella is tracking laterally, then I release automatically with the lateral arthrotomy. But now most of the time I do medial arthrotomy, and if necessary, only do a lateral release. If I had to do a lateral release, I always repair my medial arthrotomy with ethibond, so that I will have a definitely long-term hold on the medial structures, and the medial, the plication is very well done, so that the patella will track normally. The second issue is that you can have the peroneal nerve palsies, because if you correct the valgus knee, severe valgus knees, you stretch the nerve too much and you might get. So therefore, always examine the patient, and if you have the peroneal palsy, you must get your nerve conduction studies and see whether you need to release the soft tissues or whether it will recover with time. Patellar necrosis has been reported in the literature, osteonecrosis, but I haven't had any case. But because you have released both sides, medial and lateral, sometimes the patellar osteonecrosis has been reported. Right. Coming to the next topic is the complex flexion contractures. Now, sometimes you have a severe contractures. There are some degrees of contractures, 30 degrees, 30 to 60, over 60. And that type of 60, very recently we did, I think yesterday's cases, one of the cases, and that is a severe fixed flexion deformity over 60. Number one rule is that always examine the patient after anesthesia. Most of the patients after anesthesia, this fixed flexion deformities can get corrected up from grade 3 to grade 1. That is important. So therefore, remember, do not go straight away do an additional cut in the femur, right? Remember that. And also examine the patient, see whether you are dealing with the fixed flexion deformity with varus or a fixed flexion deformity with the valgus. And that also, remember that when you release the soft tissues, that also has to be counted. And this is the 2013 paper from the Jain, and that give the classification from 30 degrees, 60 degrees, and over 60 degrees. And I don't want to go into details, that he has given the common things to look for and the soft tissues. And again, as I mentioned, very important thing is, this slide is very busy slide, but he gave what to do when you have a less than 30 degrees, the more than 30 degrees, and the 30 to 60 degrees and the over 60 degrees. Now, first thing that he has also mentioned is, right, examine the patient after anesthesia, because most of the time you get even the grade 3 can come to grade 1 after anesthesia. This is another thing that I always do when I have a fixed flexion deformity. When I see that the after gap balancing and after putting the trial implant, if there's a fixed flexion still, then I do a complete posterior release on the capsule, on the femur, with the diathermy and the cob elevator. I release entire the periosteum and the soft tissue attachment of the femur on the posterior spine, and that will give you very good soft tissue balancing of and the patients get normal extension. These are the pearls and pitfalls of the fixed flexion deformity. And the important thing is to remember is that, as I mentioned again, do not cut the femur excessively at the beginning. Do the normal 2 millimeter cut first, and remove all the osteophytes, and then decide whether you need to do any more cuts after balancing. As I mentioned, you would have to examine the patient after anesthesia. Now, sometimes the quadriceps are so contracted, then you may have to do a quadriceps snap. And also, sometimes you may have to do a quadriceps plasty. I have done VY plasties and the reverse Y plasties and so on in certain patients who need to have releases of the quadriceps and the long-standing contractures. Now, remember that if you do that, then the patient may have a the post-op weakness of the quadriceps. So therefore, you have to have the braces or even the plaster cast post-operatively to manage the patients, to keep the leg in as the 0 degree extension, fully extended. And the posterior capsular release, as I mentioned, sometimes I have done tibial tuberosity osteotomy flap to get the quadriceps mechanism into a sort of a relaxed position so that you can migrate your tibial tuberosity little upwards so that you can have a quadricep laxity, and that will also help. And that occasionally only I have done. And sometimes hamstring release on the posterior side, which I have done very rarely. And one of the issues in the fixed flexion deformity is that there is a problem of skin closure. So therefore, you have to be very careful. Once you do that, your skin flaps has to be nicely released on either side to get back to the skin closure, right? As I mentioned, the quadricep weakness is there. Extra-articular deformities. Now, this is a very important point, and as you know, that the long leg films is important to identify the problems, and you have to see whether it's a femur or tibia, or whether it's a proximal to the joint or distal to the joint. Now, this is very important message, and more, if your deformity is proximal to the knee joint, your problem of joint line is severe. Whereas if your deformity is higher, your joint line is not that affected. So therefore, it is easier you to get the balance if the deformity is away from the joint. Secondly, you should see whether that your deformity is in the femur or the tibia. As I mentioned before, the femoral component always control your joint. So therefore, you must get the femur nicely aligned. Now, corrections, how can you do that? You can do three options. One, you can do intra-articular corrections with the ligament balancing, or you can do a sliding osteotomy of the condyle, or you can do outside the knee joint with the osteotomy, and where you want to do the osteotomy depending on the deformity. Now, this slide is very important slide. Now, if you have a mechanical axis, and if your perpendicular line of that joint is above your box, joint box, in other words, above the ligament attachment, it is not a case for intra-articular correction. It has to be inside the joint line so that you have to get the mechanical axis of the femur, although there is a deformity, and it has to be perpendicular line, go through the joint box where it has to be below the epicondylar line. And that is a joint that you can do correction intra-articularly. Then you come to the tibia. Again, you draw the axis, and once you draw the axis, if it is joined within the joint line, then you can do an intra-articular correction. If it is going out from the joint line, the last one, you can't do an intra-articular correction of the joint. So remember that this slide is important as long as you are having a problem with the extra-articular deformities. So before you do extra-articular deformity corrections with the joint replacement, always get the long leg films and then draw your lines and pre-plan your the surgery, because otherwise you are in trouble. Right. So intra-articular correction, again, the medial release and lateral release we already have mentioned, and that is very easy to correct. And the femoral deformity is the important, because the femur has always affect the flexion gap and the extension gap, whereas the tibial deformity correction is not that difficult if it is correctable through the joint line. Sliding condyle osteotomies, I have no experience, so therefore I'm not going to talk. If you want to read about sliding the condyle osteotomies, you must read the John Bird the papers from the France, and that he's the expert on that sliding osteotomy. He does a lot of medial sliding osteotomy and then chain the transpedicular line, transepicondyle line, and that will help to get a new transepicondyle axis, and that has been done, but I don't do that. Extra-articular correction. Now, it depends on where the deformity is. Now, sometimes you may have to do a supracondyle osteotomy of the femur or the HTO with the total knee arthroplasty, which we have done. So if I do supracondyle osteotomy, that means above the distal femur osteotomy, I always use two plates because it buttresses the osteotomy. If you use one plate, it always fails. So therefore, if you are doing a the metaphyseal correction of the deformity of the femur, you try to use two buttress plates on both sides of the femur, and you put your implant, preferably with the stem. Without the stem, even I have done with the double plating, and that gives me good results. If I do a tibial osteotomy, and then you don't need double plate, you can do one plate alone, right? And then you can do the HTO type of a surgery and then implant with a long stem. Now, if you want to read anything about this, this is a paper to go for. And this is actually published only 2017 by Santiago again from the Argentina. And that is also useful for the extra-articular deformity corrections in the arthroplasty. Coming to post-traumatic arthritis. Now, if you have the condylar fractures or the femur or tibia malunited, you can always do intra-articular correction. And then if it is a mild, you can correct it nicely. Always remember this tibial slope, and then you can correct this and then get the correction nicely if you know how to do the cuts. And then previous hardware, if you have a nail, then you have to consider extra-articular jig for the tibia or the femur, and then you can put an implant and you can correct the deformity and get the alignment also. And then if you have a previous hardware, then you can either use removal of the hardware totally or partially before to put the prosthesis. This one we removed completely, and then we waited for the healing and then did the second stage procedure of the total knee. Or you can remove all the implants in one sitting and then put a stem extension and the prosthesis. So remember that the implant can be removed, right? And then you get the long stem. And coming to complex skin incisions, you have to get with your plastic surgeons and colleagues, because there are a lot of adhesions. So you need to know what to do. And then if you have double incision, where to do, and then you release, you get this type of complications. And this is, we have seen, and all of my senior colleagues have went through this type of complications, and we have to get our plastic colleagues to help us to, when you have before, that is why before surgery, you have to discuss with them for the incisions. And post-infection, this is sometimes, it's a very difficult issues, because severe osteoarthritis and the severe osteomyelitis, you can see that when you look at that X-ray, there is no condyle on the lateral side on the femur. And severe this patient is only 47. So I had no option other than when I see that there is no condyle at all and the bone is gone. So I had to do a tumor prosthesis for that type of patient. So that is also kept in mind. Pre-operatively, you have to assess, because if you go in and find that you can't do anything, then you are in trouble. So therefore, before surgery, you plan for what you have to do, right? Thank you very much.
Thank you very much, Ananda, for that excellent presentation on these complex problems.